Haemophilus and HACEK organisms. So a patient is a 59-year-old female stroke victim confined temporarily to a respite nursing home. Symptoms: slight respiratory ailment. Symptoms 3 days after admission: stiff neck, severe headache, high fever. CSF was collected in an emergency department after transport to a nearby hospital. CSF looked cloudy. There was elevated protein concentration, decreased glucose concentration, more than 420 white blood cells per mil, and 92% of white blood cells were polymorphonuclear cells. Direct gram stain displayed many white blood cells, many small gram-negative bacilli. Some appeared to be coccobacillary with clear halos around them. CSF and blood culture: chocolate agar was heavy bacterial growth, but no growth on blood agar plate or McConkey. The organisms discussed in this chapter require special nutrients for isolation and identification, and they primarily reside in the human oral cavity, nasopharynx, and respiratory tract. These organisms that we're about to talk about are fastidious, and fastidious means difficult to grow. They require a whole bunch of extra nutrients. They're also very tough to see. So as we go through here, we're going to look at several samples of slides that are prepared, and you'll see how, because they're gram negative, they're super tiny, they kind of blend in with like debris that are found in the backgrounds of the slides. A lot of times these can go unnoticed. Haemophilus. So gram stain appearance: gram negative pleomorphic coccobacilli or rods. Coccobacilli in direct smears. Coccobacilli are just really short rods. Rods with occasionally long filamentous rods from colony growth. Non-motile, oxidase positive, catalase positive, nitrate reduction, and ferments carbohydrates. These are obligate parasites in the mucous membranes. Approximately 13 species are known to exist, and 8 species are associated with humans. Those are listed here. Most Haemophilus species are non-pathogenic or produce opportunistic infections. The major pathogens are going to be H. influenzae, H. aegyptius, and H. ducreyi. You are responsible for knowing the first and last one, so influenza and ducreyi. Haemophilus is from the Greek word meaning blood lover. Organisms prefer growth factors present in blood. They require X and V factors. X factor is hemin. Hemetin, X for unknown. V is for vitamin. Factor is nicotinamide adenine dinucleotide, NAD. So X is hemin, V is NAD. So if you're asked on a test, what is X factor known as? That's hemin. What is V factor known as? NAD. Species with the prefix para require only the V factor. So H. parainfluenzae produces X factor, but it requires V factor. Production of hemolysis on 5% horse or rabbit blood agar. Certain species are also hemolytic on SBA. The organisms do not grow in pure culture in this medium. Both X and V factors are found within red blood cells. Only X factor is directly available. V factor dependent Haemophilus species do not grow on SBA because red blood cells are still intact. But they could grow on chocolate agar, because chocolate agar, we lyse open the red blood cells, exposing that V factor. So again, in preparing chocolate agar, heat lyses red blood cells, releasing both X and V factors, and inactivates NADases. Growth of fastidious organisms around other bacteria that release the necessary growth. So in satellitism, you're usually going to have some type of beta hemolytic or alpha hemolytic species, so Staph aureus, Streptococcus pneumoniae, some Neisseria species that cause hemolysis, and they release the factors that are naturally produce V factor. So here is, for example, like Staph aureus, and because Staph aureus is degrading the blood cells around it, you will see these tiny colonies of Haemophilus arise in between the growth. And they're arising there because the Staph aureus is breaking apart the blood and giving it the ability to release those factors so that Haemophilus can grow. Haemophilus species constitutes approximately 10% of the normal microbiota of the upper respiratory tract. Most are H. parainfluenzae and to a lesser extent H. influenzae. This combination of organisms is carried by greater than 90% of healthy individuals. And colonization by Haemophilus begins in infancy. Haemophilus influenzae. So H. influenzae was erroneously named during the influenza worldwide pandemic. Infections characterized by acute inflammation in the upper airways with progression to symptoms, headache, bronchitis, severe general muscle pain. The reason for the erroneous name is H. influenzae was frequently isolated from the nasopharynx specimens taken from infected people. But after viral culture techniques were developed, it became clear that influenza was caused by a virus. H. influenzae was just a secondary opportunistic invader that happened to be present in the same area at the same time. Two patterns of disease. There's invasive disease caused by the encapsulated strains. Bacteremia, or bacteria in the blood, plays a significant role. Examples are septicemia, meningitis, arthritis, epiglottitis, tracheitis, and pneumonia. A more localized infection by the contagious spread of NTHI. Examples include conjunctivitis, sinusitis, otitis media with a fusion or middle ear infection. Before the development of the HIB vaccine, most cases occurred in children ages 3 months to 6 years. But now we have a vaccine that protects us against this. Bloodstream invasion and bacteremic spread follow colonization, invasion, and organism replication in the respiratory mucous membranes. Headache, stiff neck, and other meningeal signs are usually preceded by mild respiratory disease. Epiglottitis, rapid onset, acute inflammation, intense edema that may cause airway obstruction. The peak incidence occurs in children between 2 to 4 years of age. Maintenance of a secure airway is the most important aspect of treatment. Tracheitis, life-threatening disease in young children, arises after an acute viral respiratory infection, mild to moderate illness for 2 to 7 days that progresses rapidly. Use of broad-spectrum antibiotics is imperative because thick secretions can occlude the trachea. So here you can see the difference in infections caused by the encapsulated strains versus the non-encapsulated strains. H. ducreyi is a sexually transmitted infection called genital ulcer disease, or GUD. This is not a normal part of the microbiota and causes the disease chancroid. Painful lesion with an irregular edge, genital and perianal areas like the penis, labia, or vagina, enlarged and draining lymph nodes, known as buboes. Because chancroid facilitates the transmission of other STDs, all patients with GUD should also be tested for HIV, syphilis, and herpes virus. Less than 15 cases are reported in the United States annually. Cases are probably underreported. And this is a picture of chancroid. Low incidence of pathogenicity, otitis media, acute sinusitis. Endocarditis is rare. In the absence of other pathogens, organism may be a cause of some cases of pharyngitis. Organisms are known to die rapidly, so prompt transportation and processing are vital for maximal recovery. H. ducreyi is extremely fastidious and difficult to grow. A clean specimen site where sterile saline and sterile gauze swab base of ulcer with cotton swab moistened can also aspirate pus from buboes. H. influenzae grows on chocolate agar with bacitracin to help inhibit other organisms, especially the normal respiratory biota. H. ducreyi, GC agar. For H. ducreyi, incubate in CO2, grows best a little bit colder than body temperature, so 33 degrees Celsius. Place in culture media into atmosphere with high humidity to prevent drying. Incubate for at least 7 days before reporting a negative result. This is the colony morphology of H. influenzae on chocolate agar. It has a mousy or bleach-like odor. Encapsulated strains may appear more mucoid. There is no growth on McConkey agar. If you remember from way back in the beginning of the semester, we talked about McConkey agar and how it's typically used to isolate gram-negative bacteria. These gram-negatives won't grow on it. So the gram stain shows coccobacilli, and here's a direct smear, and here's a smear of colony growth. In a direct smear, if you're not really looking hard for it, it can sometimes blend in, especially if we're looking at a blood smear. Blood smear, there's a lot of like little platelets in the background. It's really difficult to differentiate these from the background material. So this one's a little bit easier to see because these are polymorphonuclear cells, and you can see the tiny little bacterial cells in the background. But in some specimens, it's really difficult to differentiate these. First clues that Haemophilus may be present: gram-negative pleomorphic coccobacilli on chocolate agar, and there's no growth on SBA or McConkey. Other tests are listed below here, and we use a MALDI-TOF for identification. X and V factor requirements. So the traditional approach uses impregnated strips or discs. And now we have an ID quad plate. It contains 4 zones: media with X factor, V factor, X and V, media with X and V with horse red blood cells. So this shows an organism requiring X and V factors. How do we know it requires both? Well, it's growing very close to the X factor, but the V factor is diffusing out in all directions, and the X factor is diffusing out in all directions. If it just required X, it would grow all the way around the surface of the X. If it just required V, it would grow all the way around the surface of the V. But because it's only growing in the center here, it requires both. So this picture requires V, and this picture requires X. If you are shown pictures on the test, you should be able to identify what factors it requires. There is a porphyrin test. It's an alternative method for differentiating the heme-producing Haemophilus species, and this can be done in agar broth or on a disc. The ALA porphyrin gets converted to porphyrins ALA gets converted to porphyrins or porphyrinobilinogen and intermediates in the synthesis of X factor. Kovacs reagent is added after an incubation period. Can also use a Woods ultraviolet UV lamp. A fluorescent red-orange under UV light is a positive result. If Haemophilus species does not require X factor, porphyrin positive make X factor. ALA gets converted to porphyrins. With Kovacs reagent, you're going to see the red color, or with a Woods UV lamp, you're going to see that fluorescence. So at the top, you can see it's negative, and the bottom is positive. So CLSI guidelines: respiratory tract or cerebral spinal fluid specimens, gram-negative bacilli or coccobacilli that exhibit colonies greater than 1 millimeter on chocolate agar, no growth or satellitism on SBA, and negative porphyrin, then you can identify it as H. influenzae. And here's a table with various results that help differentiate the Haemophilus species. Treatment with antibiotics. Antimicrobial testing should be limited only to isolates that are known to be clinically significant. In most cases, beta-lactamase activity to assess ampicillin and amoxicillin efficiency is necessary. So moving on to the HACEK group. So there's certain characteristics that you should know. There's a lot of information that's presented here. The goal is to give you exposure to a lot of information. So different instructors can take different approaches to this. My approach is to basically give you everything so that maybe something that I say in here will trigger a memory when you're sitting there taking that qualifying exam. But there really are like the key points that you need to pay attention to, and those I will call out as we're going through here. There are some key characteristics that I have seen come back on qualifying exam or even practice exam questions for these various species. So we're going to go through a lot of these. The basics that you should know is anything that's going to help it stick out from the other ones. So all of these are fastidious, all of these are gram-negative, many are coccobacilli, like very short rods. They're very difficult to grow and very difficult to see. They typically require the MALDI for identification, and there are some panels that we can put on the microscan or similarly like the Vitek instrument to help for identification. Pay attention to the things that make these unique. So whether it's a particular disease that it's associated with, a particular odor it's associated with, a particular type of medium that it requires for growth. So pay attention to those factors as you're going through here. Don't get overwhelmed by all of the information. Try to listen to it, take it in, and know that those key features and distinguishing factors are going to be what's most important. First of all, what does HACEK stand for? You should know this. You should know the species that are HACEK. So H is for Haemophilus, A is for Aggregatibacter, C is for Cardiobacterium, E is for Eikenella, K is for Kingella. General characteristics: gram-negative bacilli, fastidious nutritional growth, require an increase in CO2, significant cause of endocarditis. They can be normal biota if they're in the oral cavity. Opportunistics are generally require a compromised host. So here are the HACEK organisms and some of their biochemical reactions. Aggregatibacter, from the Greek word aphros or philia, foam-loving or desiring high concentration of CO2. Key causative agent of endocarditis, and it's found in dental plaque and gingival scrapings. Here you can see it on the plate of X and V. Primarily an animal pathogen, but has been found in the human oral cavity. This is a major contributor of periodontitis. So Aggregatibacter causes this, periodontitis. Key reactions are listed below. Again, no growth on MacConkey, even though it's a gram-negative. Treatment with antibiotics. Cardiobacterium hominis, pleomorphic, non-motile, fastidious gram-negative bacillus. Sometimes appear false positive on gram-stained smears. They show rosettes, swellings, or long filaments. Normal biota of the nose, mouth, and throat, and can be present in the gastrointestinal tract. Involved in endocarditis, it affects the aortic valve. Growth on SBA chocolate, not on MacConkey, and requires CO2. Pitting may be produced on agar plates. Some biochemical reactions are listed, and the usual therapy would be penicillin and an aminoglycoside. Eikenella is associated with bite wounds. Something else that's unique about this one is Eikenella sometimes is referred to as smelling like bleach. So bleach-like odor. In infections, adult periodontitis, meningitis, pneumonia, osteomyelitis, arthritis, various other types of infections. Often a yellow pigment present, non-hemolytic on SBA with slightly greening effect. Another common question that I'll see about Eikenella is its bleach-like odor and pitting into the agar. So this one actually sinks into the agar. So those are key features of Eikenella. Non-motile, non-fermenter, oxidase positive, catalase negative. Important in the pediatric population, causes osteoarthritis infection in children less than 4 years old. Predilection for bones and joints. Kingella. Strains that meet the following are abbreviated as Kingella. Gram-negative short coccoid bacilli forming large white to beige beta hemolytic colonies on SBA. Doesn't grow MacConkey. Catalase negative, oxidase positive. There's spreading colony and smooth convex and beta hemolytic colonies. Biochemicals are listed. And switching gears to capnocytophagia. So there are 6 species associated with human disease. They are part of the normal microbiota. The most common clinical isolate is C. ontracia, more common in septicemia than endocarditis. These are fastidious, facultatively anaerobic gram-negative bacilli, require CO2 for growth. Gram-stain, they're thin and often fusiform or pointed ends, and curved filaments may be seen. So here you can see what they look like under the microscope. Very long. Some of their biochemical reactions are listed here. And here you can see it on a plate. Pasteurella. Pasteurella causes pasteurellosis, which is a zoonosis, means that it's transmitted from humans to animals, animals to humans across different species. Animal bites, often those a result of cat bites, are the most common. Organisms live in the respiratory tract and oral cavity of birds and mammals. There's systemic infections, pneumonic, soft tissue infections, often resulting from animal bites, and cutaneous infection can quickly progress, inflammation, and exudate production. At least 17 species have been identified. Most commonly isolated is Pasteurella multocida. Description is listed below. Pasteurella, think animal bites. And there's some more growth characteristics. Again, these are fastidious. They don't grow on McConkey. Brucella. Brucellosis is another important zoonotic disease. This one is more associated with milk, especially in animals that are in areas where they don't vaccinate their animals against this. Brucella has a potential application in bioterrorism, so these are considered Category B select biological agents by the CDC. Brucellosis may be described by the disease course, like undulant fever, or the geographic location where cases have occurred. Subpopulations at high risk include individuals exposed to animals and animal products and laboratory workers. Transmission routes, aerosol. So the aerosol transmission makes this organism of great concern. There's acute, subchronic, and chronic cases of brucellosis. Acute, you get exposed, so within 1 to 4 weeks after exposure, you start with fever, malaise, headache, anorexia, myalgia, and back pain. Subchronic, or undulate form, low temperature in the morning, followed by rising temperatures in the afternoon and evening, within 1 year after exposure. Arthritis and epididymochitis may occur. Chronic, depression, arthritis, and chronic fatigue syndrome around 1 year after exposure. Microscopic appearance is small gram-negative, aerobic non-motile encapsulated bacterium, coccobacilli or bacilli in shape. Under optimal conditions, a smooth, raised, and translucent colony, and can reside within mononuclear phagocytic cells. They are strict aerobes, grow on SBA and chocolate, can be isolated on MTM. Plates should be held for 4 days before reporting negative. There's some biochemicals, and then other methods include molecular techniques. And here are different types of organisms and how you would differentiate them from Brucella. Special handling requirements. So I mentioned this earlier, but because of the aerosol mode of transmission, brucella should be handled under biosafety level 3 conditions within a biological safety cabinet. Approximately 2% of all reported brucellosis cases are acquired in the laboratory. So biosafety level 3 means that you're in a secondary containment room, typically in a negative pressure area with extra filtration. Negative pressure prevents the air from within the room from circulating out of the room. So it kind of keeps that air in the room. And then you would be working under a hood within that room, in that secondary isolation, negative pressure room. Francisella. So Francisella tularensis is the causative agent of tularemia. This is a species implicated in most human infections. It's zoonotic disease contracted through ingestion, inhalation, arthropod bite, or contact with infectious tissues. This is associated with rabbits in Europe. There's the ulceroglandular and other forms of the infection that exists, but the most common form is that ulceroglandular. Ulcer forms at the inoculation site following by enlargement of regional lymph nodes. This is a CDC Category A select biological agent because it poses a risk to national security because organisms can be spread through person-to-person contact or are easily disseminated. It also results in a high mortality rate. It has a very small infectious dose and a very high likelihood of death. It is a CDC reportable disease, and about 100 to 200 cases are reported annually. General characteristics are listed below. The agar of choice is buffered charcoal yeast extract, BCYE. That is a distinguishing feature, an important feature of Francisella growth. So there's some biochemicals that are listed here, but then there's also direct fluorescent antibody testing. So immunohistological staining with monoclonal antibody. So we put an antibody that's fluorescently labeled directly on the tissue, and then we wash any unbound or excess antibody away, and if fluorescence is still detected, then it's positive. We can also confirm using MALDI. Safety considerations. It's a highly infectious agent with as few as 50 organisms causing a massive infection through the cutaneous, ulceroglandular, or inhalation pneumonic routes. Causes laboratory-acquired infections. Personnel should use appropriate laboratory safety techniques and precautions, and BSL-3 should be implemented. Legionella. Legionella is a ubiquitous gram-negative bacilli. Ubiquitous means it's found essentially everywhere. Approximately 26 species isolated from humans, primarily acquired through the inhalation from environmental sources. Methods of isolation are listed. There's also direct fluorescence antibody detection and PCR. It produces a spectrum of symptoms, asymptomatic or mild upper respiratory tract infections to life-threatening pneumonia. Febrile diseases, known as Legionnaire's disease, Pontiac fever, or there's an asymptomatic infection. So if you're asked a qualifying exam question that says, which of the following causes Pontiac fever? You should know it's Legionella. Or which of the following causes Legionnaire's disease? Legionella. So intracellular parasite enters and multiplies within host cells, particularly bronchoalveolar macrophages. Predisposition for disease includes immunocompromised, patients with chronic lung disease, alcoholics, and heavy smokers. It manifests in 3 major patterns: sporadic, epidemic outbreaks, and healthcare-associated clusters. Legionnaire's disease, so the atypical pneumonia, is a type of pneumonia that produces symptoms that are different from those caused by S. pneumoniae. It's the most common causative agent is L. pneumophilia, serogroup 1. Pontiac fever is a non-pneumonic form of legionnosis. Short incubation period of about 2 days. In previously healthy individuals, you develop flu-like symptoms that last 2 to 5 days and then subside without medical intervention. Disease might not be caused by inhalation of a bacterial toxin. Disease might be caused by the inhalation of a bacterial toxin, such as endotoxin or acute allergic reaction to a bacterium. Approximately 5,000 cases of legionellosis reported each year in the United States. Many cases go undiagnosed. Physicians might not suspect it, and many laboratories do not routinely culture for these agents. Legionella is associated with healthcare-associated infections, often linked to contaminated equipment and water lines. So causes 2 to 15% of a community-acquired pneumonia. Incidence is likely higher than what's reported. Legionella is found in natural bodies of water. This makes it unique, and this is a key feature that you should make note of. Lake, river, springs, man-made water treatment systems, it can survive in chlorinated water up to 3 mg per liter. Specialized sources would be heating and cooling towers of buildings and fountains. Can colonize a variety of sources due to its ability to multiply at large range of temperatures and survive in temperatures that are really high. Adherence to pipes, rubber, and plastic, and the ability to survive and multiply within free-living protozoa in the presence of commensal bacteria and algae. Multiple methods are available. Typically, we have the PCR panel that it's a portion of, and it can detect it. There's a urine antigen detection, which Legionella is routinely tested for in the urine. And Pontiac fever diagnosis is based on laboratory findings, environmental studies, and epidemiology. The microscopic morphology is listed here. Acid-fast or modified Kinune procedure may yield the desired organisms. You can see how difficult it is to see this. So the untrained eye would just look at this and be like, oh, yep, it's just loosely staining cells. But then when you start to look a little bit closer inside, you can see the shape of the bacterial cells. So some isolation methods, it grows best on that BCYE, buffered charcoal yeast here. And you can see here, this is non-selective BCYE, and this is selective BCYE. You can see what the colonies look like on each. So MALDI-TOF is used for identification, and then biochemical testing is not really any longer used. There's also DFA, direct fluorescence antibody testing for Legionella, and you can see when using specific antibodies that are designed to attach to or bind to Legionella, you can see how they fluoresce. So you would fix the tissue sample and bacteria, you would apply the antibodies, you would wash away all of the unbound antibodies. The antibodies themselves are fluorescently labeled through procedures identified in an immunology course. Then you would be able to see the fluorescence on the surface. And here is the common physical and biochemical characteristics of Legionella. So kind of a quick reference sheet. Rapid methods, there is a urine antigen test that's available. It's an immunochromatographic assay for Legionella antigen detection. And this, very similar to a pregnancy test, you've got antibodies on there, the specimen will go past, the control line will turn positive, and then you will have the test line either positive or negative. For serological testing, indirect fluorescent antibody test assay is the most common. Bordetella. So Bordetella, major pathogens are Bordetella pertussis and parapertussis. Both of these are agents of whooping cough. Other Bordetella species are listed below. Some characteristics are found here. Whooping cough, exposure and incubation period of 1 to 3 weeks, initial cold or flu-like symptoms, sneezing, runny nose, and then you go into the catarrhal phase, 1 to 2 weeks, and it's highly contagious. Once you slip into the paroxysmal phase, sudden severe repetitious coughing followed by a whoop. Rapid gasp for air can be followed by vomiting. You can cough so much that you break blood vessels in your eyes. Can cause serious infection in young children, cyanosis from lack of oxygen, sometimes need assistance in keeping the airway open. The convalescent phase begin recovery about 4 weeks after the initial symptoms, decrease in bouts of coughing, but it may take weeks or months to complete resolution. Adults may or may not experience respiratory symptoms, and if they do, the symptoms can vary. Persistent cough to chronic bronchitis. Sometimes the organism will die and be removed from the body, but it's the damage to the alveoli that is left behind. So once the alveoli are damaged, it decreases oxygen exchange and it causes a lot of debris and buildup in the lungs, and that can stimulate the coughing reflex. There's no known animal or vector reservoir. Infections acquired through respiratory tract via respiratory aerosols or direct contact with infectious secretions. This is one of the most highly communicable diseases of childhood, but there is a vaccination series that's available for children, Bordetella pertussis, the P in DTaP or Tdap vaccines. Those vaccines protect against this. And that vaccination is recommended to be repeated later on in life, especially when a mother becomes pregnant. Mom gets vaccinated, baby passively receives those antibodies from mom. There have been recent outbreaks of whooping cough in the community and even amongst vaccinated populations. So that was a slight concern earlier on this year. There are other miscellaneous species, like Bordetella bronchoseptica is a very important veterinary specimen because it causes kennel cough in animals. It can be transmitted to humans and cause nonspecific cough, bronchitis, and the symptoms are common in patients with underlying conditions. Laboratory diagnosis, culture isolation with or without molecular testing. DFAs have low sensitivity, they're not recommended. Other strains have no role in identification. The organism is not likely to survive well outside the host, so that's why we prefer DNA typing or testing. Nucleic acid amplification methods can circumvent many of the problems associated with trying to grow it in the first place, but it may produce false positive results due to lack of standardization of the single target testing. Laboratories should use at least 2 DNA targets. Culture, Bordet, Gengu, potato infusion agar with glycerol and horse or sheep blood agar. So for Bordetella, this is the agar to know. Colonies are smooth silver pinpoint resembling mercury droplets. And on Bordeaux Gengu, colonies are beta hemolytic. And this is what colonies look like. There are some various methods for identification. The MALDI is one of the most sensitive if you can manage to get it cultured. And here is a summary of laboratory diagnosis of pertussis by culture. And differential characteristics of Bordetella species. Serological testing is used to study outbreaks and document seroconversion after immunization or infection. It can identify more cases in older vaccinated children, adolescents, and adults. Assays cannot distinguish an immune response between vaccination or infection. So if we look for antibodies, we can't tell Were the antibodies because they were vaccinated previously? Were the antibodies because they were exposed previously? Or are the antibodies because they currently have the infection? So we usually just detect the antibodies to determine outbreaks. Detecting anti-pertussis toxin antibody by enzyme immunoassay or bead-based assays is recommended for diagnosing exposure. Antimicrobial susceptibility testing is indicated in certain situations. And that is it.